A very warm good afternoon to one and all, and I welcome you to this instruction course on abnormal head postures in ophthalmology, and we are trying to present an ophthalmic perspective of abnormal head postures, including all subspecialties, and I hope you enjoy the session. We have some very eminent speakers in this session, and the first one would be Dr. Fatima Allapichai. She's an Associate Professor of Ophthalmology at Arvindai Hospital, Tirunelveli. And why I chose her for this IC was that she has developed a specific tool to measure abnormal head postures, and what do you call it? A single arm tool. A single arm tool which is less cumbersome as compared to the regular goniometer that we use to measure the abnormal head postures. So I welcome you, Dr. Fatima, to this instruction course, and and questions are open. If you have time after each talk, we can take some questions, or we can club it at the end depending on the flow of the talk. So, I invite Dr. Fatima Allapichai to give her talk on abnormal head postures, causes, differentials, evaluation and measurement.
Good afternoon, everyone. First of all, I like to thank Dr. Neena and Ksos for this wonderful opportunity. Let us go through what is abnormal head posture, causes, differentials, evaluations, and management. So, abnormal head posture refers to a condition where the head is deviated from the usual upright posture, that's all. So it could be either face turn or chin up down or head tilt, and sometimes combinations, here head tilt as well as chin up kind of head postures we can see. So first step is to differentiate whether it is ocular AHP or non-ocular AHP. Ocular AHP, the prevalence is around 18 to 25%. 1.1% of the patients presenting to ophthalmic clinic has an AHP. So based on the previous studies, based on a review literature, if you note the causes for anomalous head posture, we could find there are multiple type of concomitant squints. Among that, superior oblique palsy ranks first, and nystagmus is the predominant cause in another study. And interestingly, Dr. Burton Kushner had shown 4 cases of cosmetic abnormal head posture. So to hide the conjunctival scar or some palpable fissure changes kind of things. And this study, this 162 number is due to, they have included other neurological causes as well. And here they have told 9% of the patient had habitual abnormal head posture. That entity also we should remember. Once we rule out everything, we can go for it. So these important ocular anomalous head postures, one by one, next speakers will cover. I like to mention these also because we have to know about these so that we would appropriately refer the patient to the appropriate specialty at correct time. So among non-ocular, congenital, if you see, congenital non-ocular head posture, mostly it includes that sternocleidomastoid contracture due to fibrosis. 1 in 300 children presents to the orthopedic clinic, and the typical finding is its onset is before 6 months, even at first week of age, unlike ocular anomalous head posture where it emerges after 18 weeks of age once fixation develops. So these are all the differentiating factors. We can also do a patch test. When you apply patch, the head posture being not altered, it says it's not ocular head posture. And otherwise, grown-up children, you can ask the child to close the eyes and be for a few minutes and observe if the child is cooperative enough. Otherwise, you can very well ask the patient's parents about the history during sleep, how the child's head posture is during sleep. Mostly, if it is normal during sleep, it will not be ocular, unlike secondary muscular contracture developed kind of situation. Even there, you can inquire about earlier history. The exception for this patch test is nystagmus for the obvious reasons, where we will not go for patch test because the reason is there obviously. So coming to acquired causes, traumatic, okay, you know the history will be there. Among non-traumatic, you have reasons due to infections and inflammation. It could be musculoskeletal, somewhere cervical vertebra, brachial plexus infection, inflammation could be there. Importantly, you should not miss that retropharyngeal abscess because it is quite endangering life if it is missed and get treated appropriately at the early at the onset of the disease. So next is the ENT causes, where vestibular imbalance and nasopharyngeal infections. And the most common another cause is unilateral hearing impairment, where the patients will tend to turn their head towards the good ear. And another aspect is neurological. That is again very important because the posterior fossa tumors and all, 22.2% of the tumors start with the early sign of anomalous head posture. So it is important to pick up. Sometimes the patient may be roaming here and there, not getting properly imaged. So if it is acquired AHP, we should be very careful, and also we have to look for a drug history if the patient is taking any of these. And this different gastrointestinal cause is also there, where the child can, with hiatus hernia, the child can adopt a posture to prevent acid reflux. So these are all the different, after ruling out everything, we can go for the psychogenic AHP or even sometimes habitual. So these are based on a multidisciplinary study. Orthopedic causes leads the first, and then ophthalmic and neurologic. But anyway, I have not included this voluntary head postures, but soon in future it may become involuntary due to muscle fibrosis and may reflect upon orthopedic clinic. So coming to evaluation and measurement, for evaluation, you have to definitely spend some time just in clinic with a close setup. You cannot rule out some abnormal head posture. Sometimes parent will be constantly mentioning, but you may not pick up. So we have to spend dedicated time and provide a distant as well as near target. Particularly distant target, the patient will not be will be in a comfortable situation. So the patient will come out with the head posture, and we have to induce visual strain. We can provide for this age, we can provide some interesting cartoon movie, and for grown-up children, we can tell them to read the Snellens in a reverse fashion, or you can even tell them to calculate, add the numbers, subtract, so that the patient should forget that we are monitoring them. So they come out with the whole head posture. And there are ways to measure. There is a smartphone application by iPhone, where they have this landmark here. And here also, seating also there is a line, but our patient's outfit will not match this seating, right? Saris and dhotis. So, and also another drawback is mentioning proper positioning of iPhone is essential. And not only in iPhone, other softwares are also available. They are very good in documentation and for research studies. But the drawbacks would be the cost involved and the technological knowledge needed and the time involved, and moreover they don't talk about the chin up-down measurement, Z-axis measurement. Coming to the conventional goniometer, where we have two arms, one arm is the reference arm, right? So it should be kept in either parallel to the room or perpendicular to the room. Imagine in a complex room, it would be there would be a subjective variation. That's what our feeling. So we came up with the device that we named single arm tool, because the standard reference arm is replaced by either gravitational force or direction of seating arrangement. Here we are for this one, the clinometer. The clinometer is used by engineering students, where that one weight will be hanging in the center. So we have done it by do-it-yourself method, where a simple protractor is taken. Nowadays the protractor comes with the pre-made hole in the center. So through that we can hang some small weight to it. You can hang by any way, but you have to make sure this, you have to make sure it should smoothly swing here and there, so that now the device is ready. So what we are going to do is, just we are going to align that one particular arm, that plastic part is, we have attached to it to give it one arm. So that arm is aligned to the lateral canthus, and the remaining standard arm will be taken care by the gravity, right? So, but the problem is, we have measured this whole angle, but we want only this angle, right? So what we are going to do is, we will subtract this 90 degree from what we measured for chin up, and measure the value from 90 degree for chin down measurement. Yeah, this is again chin up measurement. If you want to make sure the reading, at once you will get the reading. If you want to make sure the reading, you can even swing and let it settle, then you can take again. Yeah, this is what I was talking about. You have to subtract this portion. And for head tilt, similarly, we can. The problem with the conventional goniometer is this one will come in the view of the patient, right? So the child will alter his or her head posture. So without disturbing the patient, allowing them to read the Snellen, and still we can comfortably take the measurement, because the second arm is very short. And for a face turn, we cannot go with gravity, that clinometer, so we have to take some other reference arm. So what I have done is, this compass we have put in the center. So this is the, and when we have put one yoke dial, we have fitted one yoke dial around the compass, so that after determining the seat position, we can even draw a line or something, and we have to adjust the zero value according to the seat position in that goniometer. And when this compass is aligned meaning that red color pointer should be facing the north, that's all. So once it is done, we can start measuring. So the other arm is taken care by the compass. Now this single arm can be aligned with the nose, and the reading will be obtained from the yoke dial. For a particular seat arrangement, we need not turn the yoke dial thereafter. So to conclude, the determination of cause, thorough evaluation, and proper measurement of anomalous head posture are the key factors in management. Thank you. Thank you for your listening.
Thank you, Dr. Fatima. The next speaker can be ready. So while the next speaker is ready, I have a question for Dr. Fatima. So have you done any comparative analysis between the standard goniometer and your instrument, and what are your results?
Yeah, we have done with our colleague, our one doctor. He did his measurements in conventional goniometer, and he did with both. So there was only 0 to 2 degree difference. So it was, I mean, it's no comparison. It's similar to goniometer, nothing great to learn in it. Just we have to make sure that it is freely swinging, and that's all I think.
So thank you. That was really interesting, and congratulations to you for that innovation. So we move on to our next talk, and it is by Dr. Shebin Salim. She's a budding oculoplasty surgeon from Giridhara Institute, very active in all conferences, and she's going to talk about abnormal head posture due to diseases of orbit and adnexa.
Thank you, Dr. Nina, for your kind words. Good afternoon, all. We'll directly go to the presentation. So this is a 4-year-old girl who presented with the right eye severe ptosis since birth. Her visual acuity is 6/6 in both eyes. So the chin up posture that she is having, this helped her to have a binocular vision and prevented visual deprivation amblyopia in the right eye. This is simple congenital ptosis. Next, we have a 4-year-old boy. Actually, this patient presented to us at the age of 1. He had bilateral severe ptosis. We can see that there is telecanthus, blepharophimosis. This is BPS, blepharophimosis, ptosis, epicanthus inversus syndrome. So despite bilateral severe ptosis, we waited till 4 years of age for the ptosis correction because there was no amblyopia, and the chin up posture helped to prevent the amblyopia. And we waited till 4 years of age to get a better soft tissue development. This 12-year-old boy presented with the left eye mild ptosis since birth. So here we can see that he is having a left hypotropia and elevation restriction in the left eye in all cases. So this is monocular elevation deficit. Here the ptosis can be pseudotosis because the lid follows the globe, that is down, but in 25% of cases this can be true ptosis. So this is another lady who presented with a progressive bilateral ptosis since past 20 years. So here we can see that in other than bilateral ptosis, she is also having a generalized facial muscle wastage. So this in her there is progressive, both extraocular movements are restricted, bilateral symmetrical. So this could possibly be an isolated CPO, but before diagnosing it, we have to rule out other causes of progressive myopathy, including paraneoplastic syndrome. So this is a 3-year-old girl who is having squint and an abnormal head posture. So we can, she is having a face turn towards the right side, mild chinna posture. So here again, she is having a elevation restriction in the left eye only in adduction. So this is Brown syndrome. It is a form of restrictive strabismus where there is mechanical restriction of the superior oblique tendon trochlear complex. So in subtle cases of Brown's, the squinting can even be missed. So this boy again presented with an acute onset squinting. So here we can see that he is having an elevation restriction in adduction in the left eye. So this was a case of acute Brown syndrome. So first we did all the blood investigation to rule out the possible etiologies of acute Browns, and the imaging showed soft tissue, minimal soft tissue thickening at the region of the trochlea on the left side. So initially we tried a course of oral steroids, but no improvement. So we went ahead and did a small incisional biopsy from the trochlear region and an intratrochlear steroid injection. Incisional biopsy only showed non-specific inflammation. This is at the end of 8 weeks with oral steroids and intralesional injection, he improved completely. So this girl, can you see the abnormality here? So she is having a prosthetic eye on the left side. So possibly there is a phase turn to the left eye, maybe for a better field of vision. So that is, it's not seen in all the patients' anophthalmic socket cases, but some patients we see this abnormal head posture. So this 63-year-old gentleman, he presented with the acute onset drooping of left eye. So here we can see that imaging, there is enlargement of the left superior rectus and LPS muscle complex with an adjacent lacrimal gland inflammation. So here he is again adopting the chin up and face turn. One is for a better field and also to get vision with the left eye. This was another interesting case. He presented with acute onset diplopia and right eye drooping. So cover test for both distance and near showed a left hypertropia which was increasing on right gaze and left tilt. So this is left superior oblique palsy. Extraocular movements are full. So eyes test was positive. So possibly this is a case of ocular myasthenia. He was sent for further investigation. Usually in myasthenia, the recti muscles are involved. Oblique involvement is very rare. So this was a 14-year-old girl. She is having a chinna posture, but whenever we take photos, we actually correct the head posture and take. So here we can see that she is having a complete elevation restriction in the left eye. Imaging showed, this is MRI imaging, sagittal showing a large cyst in the inferior rectus muscle. So this was inferior rectus myocystic This should be treated with oral albendazole and steroids for 6 to 8 weeks. So, and it is very important to start treatment as early as possible in these cases to prevent fibrosis of the extraocular muscles and residual diplopia. Again, similar case, cysticercosis of the orbit. So here we can see that the cyst is lodged between the optic nerve and the middle rectus muscle. So the child is having face turned towards the opposite side. The right eye, there is adduction restriction. So this is after treatment, there is complete improvement. So this was this lady, in fact, initially presented with a sight-threatening thyroid eye disease, and she was treated. Then she developed cataract. Following cataract surgery, she started having diplopia. So we can see that she is having right esotropia and a slight face turn towards the right side. She underwent squint surgery. So this was a 5-year-old girl who is having an abnormal head posture from birth. So this, she is having a plagiocephaly on the left side. So flattening is here. So what happens here is there will be shortening of the roof. This in fact causes a superior oblique deficiency with a desagittalization of the images. So to overcome that, the child will adopt a head tilt. Because of the head tilt, there will be there will be hypoplasia, facial hypoplasia. So this can be prevented if we do an early surgical intervention before 3 years of age. Another interesting case of orbital floor fracture, the child is avoiding the right orbital floor fracture with inferior rectus entrapment. Child is avoiding the maximal action of the inferior rectus muscle, that is a down and out position. So this gentleman, he had a frozen globe on the right side. He presented with the complaints of diplopia. He has a chinna posture. So we can see there is a inflammatory mass on the inferior and middle aspect of the orbit. So this incisional biopsy was done. PCR was positive for tuberculosis, treated with ATT. Then he had a recurrence. Again, biopsy was done, which showed only fibrosis, which we still don't know the diagnosis exactly. But his ocular movements did not improve. So this is golden horse syndrome, that is oculoauricular vertebral dysplasia. Here the abnormal head posture is not exactly due to the ocular condition, but because of the vertebral anomalies. So a lot of conditions including ptosis, monocular elevation deficiency, Brown's, inflammatory conditions, parasitic, anophthalmic socket, fractures, all these can cause abnormal head posture. So whenever we see an abnormal head posture, we have to evaluate for it. Thank you.
Thank you, Shebin, for that excellent demonstrative cases. And now we know that there is always a reason for the head posture. So I invite Dr. Lakshmi. She's currently consultant at Malabar Medical College. She's professor at Malabar Medical College and consultant at Abbott Hospital, Calicut. And she's going to talk about an approach to pattern strabismus causing AHP. If there are any questions, we can take it at the end or in between. Please feel free to ask questions.
Okay, thank you, Dr. Neena. And I'll be dealing on head posture caused due to pattern strabismus. So before going to what is the head posture, just a briefing on pattern strabismus. So what is pattern strabismus? It's a vertically concomitant horizontal strabismus and a substantial difference between down gaze and up gaze. So what is the substantial? 15 prism for a V pattern, 15 prism of difference between the horizontal deviation in up gaze and down gaze for a V pattern, and 10 prism for A pattern. And the measurement is done at 25 degrees up gaze and 35 degrees down gaze by tilting the head in the chin up and chin down posture. It's seen in 12 to 50% cases of horizontal strabismus. We do see occasionally Y pattern and lambda pattern, but it's not very common, so we'll stick to A and V patterns for now. And if we see this child in the first photograph, he has a V pattern esotropia, and you can see the ESO is increasing in down gaze. The picture on the right shows a V pattern exotropia where the divergence is more in up gaze. So the next patient is an A pattern exotropia. In this you can see that the eyes are diverging while looking down. The other thing that I need you to note in these are the 9 positions of gaze. So if you see these up gaze pictures, we can see that there is an inferior oblique overaction or an over elevation in adduction seen in this patient and in this patient, both these patients. And in the next picture, if we see, there will be an over depression on adduction, that is a superior oblique overaction in down gazes. So far said, we come to the first step of measurement of pattern. So the pattern strabismus head posture is important in 2 aspects. One is a pattern strabismus can cause a head posture, and the second thing is when we are measuring a pattern strabismus, if we don't correct the head posture and the patient is keeping a head posture, our measurements might go wrong. So measurement of pattern is of utmost importance. We need to measure the patient in 9 positions of gaze and find out which muscle is overacting to find out oblique overactions. Keep in mind pseudo patterns where we get V pattern, which is not actually a V pattern, it's due to an uncorrected accommodative esotropia, and a pseudo V pattern exotropia in intermittent exotropes who fuse in down gaze. So coming to the head posture, the classically described head postures in V and A patterns are chin up and chin down, and typically it is mentioned for people who fuse in these head postures. So a V pattern exo and an A pattern exo will fuse in chin up, and A exo and V ESO will fuse in a chin down posture. But when we assess the head posture, we need to see whether the patient is actually keeping a chin up or chin down, or is there something else along with the pattern strabismus. So this is the V pattern ESO boy. On close follow-up, he has a right head tilt and a left head tilt. So he had an associated dissociated vertical deviation along with the pattern strabismus. So that was giving rise to the tilt most probably. And he was alternately suppressing his eyes. So this is the patient with an A pattern exotropia, and in these pictures we can see that the patient is keeping a chin down posture, but along with it she has a small right head tilt, and in this position the exotropia is actually more, and she also had a DVD. This was a patient with Helveston syndrome, A pattern exotropia and DVD. And as already mentioned, craniofacial abnormalities we need to see for plagiocephaly. We can have a a V pattern, but it's not actually due to an oblique muscle overaction. So the next thing we need to check is, why are we bothered about this? Because as seen in the other pictures, it could be to facilitate fusion, it could be to separate the images as far as possible, it could be due to an associated DVD, or in the plagiocephaly case that I showed, she didn't have an abnormal head posture because she had amblyopia in one eye. And it could be a combination. This will influence the management. So we need to know a little bit about why pattern strabismus is caused. As seen above, the overacting muscles or the orbital anomalies could be a cause, or it could be due to loss of fusion. So loss of fusion is told to produce a torsion which can cause an abnormal pattern. But this theory doesn't hold good, because there are patients in which you see pattern strabismus and overactions, but we don't see a torsion. So we need to assess the torsion in these patients. And almost all cases of oblique overactions, if we see a torsion, it is definitely an oblique overaction and it is not some other thing. And the next step would be to assess the level of binocularity. Most of the congenital strabismus patients with patterns have a subnormal binocularity, but acquired cases or late onset cases can have a good binocularity. So if we are tackling the obliques, that can result in a torsional diplopia. So how do we manage? If the obliques are not involved, we upshift or downshift the horizontal recti, and medial rectus towards the apex and lateral rectus towards the base of the pattern. And in oblique overactions, we should tackle the obliques necessarily. And suppose the inferior oblique is overacting, if there is a dissociated vertical deviation, it needs to be corrected along with it. So we might need to do an anteriorization procedure along with the recession of the inferior oblique. So these are the pre and post of the other two patients that I showed before, the V pattern ESO. He underwent bimedial recession with inferior oblique anterization because he was having a dissociated vertical deviation. He was pretty much okay. The pattern has almost collapsed. And head posture, I'm yet to assess because it was just the third day post-op. And the second patient with Helveston syndrome, her preoperative head posture and head tilt actually subsided to a large extent, but she was not having a good fusion. She does a lot of videos, so this is the post-op video, and that doesn't show a significant head posture. She underwent a bilateral lateral rectus recession with a posterior tenectomy of superior oblique and an IR plication for the DVD. So her pattern also had collapsed. To sum up, pattern strabismus and abnormal head posture can appear complicated. We need a stepwise approach. We need to assess the binocularity, always assess the torsion, and don't hesitate to operate on the obliques if it is necessary, and no single approach might work in these cases. Thank you.
So, in Helveston syndrome is probably the worst strabismus you can get, I think. So there are some, thoughts on doing all the
obliques. Yeah.
So what is your experience? Have you touched on?
No, that was only one patient of Helveston I had seen. I had followed up her for I think 3 or 4 years, because initially they were not willing for surgery. She had associated quadriplegia or something, cerebral palsy sort of problems. But her mentation was fine, and she didn't have significant She didn't have binocularity. One eye, she was suppressing one eye. So, and torsion was there, significant torsion was there. So I planned to go ahead with dealing with the obliques, superior oblique alone, than dealing with the inferior oblique, because I felt that was a little bit more conservative than going in for all the superior obliques, because I didn't want a abnormal result to the superior oblique. But inferior rectus plication for the DVD gave a good result.
But if at all we are doing, I think, staged, right?
Stage, two procedures.
Yeah, thank you. Now we call upon Dr. Neena. She is senior consultant in Gridhar Eye Hospital, a very dynamic strabismologist. Over to you, Dr. Neena.
Thank you, Dr. Fatima. And I'll be talking on tackling strabismic causes of abnormal head posture. So I'll be talking about both restrictive and paralytic head posture causes. So let's look at this case. He's a 21-year-old college student. You can see that he has a very prominent left face turn. And if you look at the video, you can see that there are some palpable fissure changes in the left eye on adduction, -3 abduction, and he has a left esotropia. So this is a classical esotropic Duane's retraction syndrome with left face turn. So he was concerned not about the squint, but about the abnormal head posture. So you can see this is his, we went ahead and did a weakening of the medial rectus in the left eye because he was esotropic, along with a superior rectus transposition to the lateral rectus to strengthen his abduction. And you can see here that his abduction did improve from -3 to -4 to about -2 to -1. And he was happy because his head posture was much better. So this is a SRT which is being happening, and we can augment it with non-absorbable sutures if you wish to strengthen further. So this is another case of a 7-year-old boy. He again has an abnormal head posture, a left face turn. He was ridiculed by his classmates, so he was not going to school. He stopped going to school. So his parents brought him to me. And again, you can see very small esotropia in primary position, but significant abduction restriction, -3, and palpebral fissure changes are there. So we did the same thing, a medial rectus weakening of the left eye, along with a superior rectus transposition to the ipsilateral lateral rectus. And you can see the dramatic change in his head posture pre and post surgery. You can have a little more complex case. Look at this boy. He has a very prominent left face turn and also some facial asymmetry. And if you correct his head posture in the primary position, you can see that the right eye is hypertropic and esotropic, and he has an abduction limitation in the left eye and palpebral fissure change in the left eye. So this is a left ESO-DRS, but fixing with the left eye. So the secondary deviation is manifesting in the right eye. Along with that, he also has a DVD, a dissociated vertical deviation of the right eye with inferior oblique overaction. So I'll show you a video. We first thought it was superior oblique palsy, but when you look at his video, you realize it is only a dissociated vertical deviation in the right eye. He was amblyopic also. So what did we do for him? His FDT was positive for medial rectus. We did a small medial rectus recession in the left eye and a larger recession in the right eye. Along with that, we weakened the inferior oblique of the right eye because he was amblyopic and he was fixing with the DRS eye. So you can see that post-surgery, his head postures improved very well. He was quite happy, and his squint also became much better. So this is another child. You can see she has a left face turn, and this time the culprit is not the left eye, it is the right eye. You can see in primary position she has a significant exotropia and an adduction limitation with palpebral fissure changes and also an upshoot. So this is a classic exotropic Duane's retraction syndrome, and we did a lateral rectus recession with a Y-split of the lateral rectus in the right eye, and you can see she's much better, and the upshoot is also better controlled and a face turn improved. So sometimes you may have adult patients like this also coming to you with head posture. This lady has a thyroid orbitopathy, and she has a significant restriction of abduction in both eyes, more in the right eye. She had a large right face turn. And we just did an medial rectus recession. Also, she had some vertical strabismus, so I had to do some inferior rectus recession in the right eye. She's awaiting surgery in the left eye. She still has some ESO, but she's much better. So this was a 28-year-old painter. You can see the classical right head tilt, a left hypertropia increasing in right head tilt, increasing in left head tilt and right gaze. This is a classic left superior oblique palsy, very severe diplopia. So this is his head posture, and we did an inferior oblique recession of the same eye along with an inferior rectus recession of the contralateral eye because he had a very large esotropia, hypertrophy of the left eye. So post-surgery, he was quite happy. His head posture was well corrected. This was a gentleman. He had a road traffic accident and he had bilateral 6-nerve palsy with very large ESO deviation of the right eye, and he had a right face turn. So we did bilateral medial rectus recession and superior vertical rectus transposition to both the lateral rectus, and this was one of the old cases which I did. Now I have shifted to either SRT or Nishida, but we did vertical rectus transposition to lateral rectus in both eyes, and he had pretty good cosmesis and improvement in his head position. So this 6-year-old girl came to us after an excision for pontine glioma and radiotherapy. So this is a corrected head posture. She has a very large right face turn and a large right esotropia. You can see both eyes, the abduction is limited. So this is after we gave Botox to the medial rectus. You can see improvement in her ESO. And finally, after bilateral medial rectus recession and an SRT to the lateral rectus, she's much better, head posture is better, though the abduction is not complete. This 5-year-old boy has a classical chin-up position, ptosis. This is a classic monocular elevation defect, a right hypotropia. You can see that elevation is -3. And we did a modified Nishidas for him, and his abnormal head posture and ptosis and hypertropia improved very well. So in Nishida, there is a no tenotomy, no disinsertion surgery in which you take bites with non-absorbable sutures from the horizontal recti and transpose it to the superolateral and supromedial scleral compartments. So this gentleman had a stroke in Pons, and this is what he developed, a left horizontal gaze palsy. This is him looking to the left, absolutely no movement of the eyes to the left. But he also had a true lateral rectus palsy or 6-nerve palsy. So very complicated strabismus. This was how he was earlier, and you can see after a medial rectus recession of the left eye and a superior rectus transposition to the lateral rectus, he's much better. Probably he'll need a second sitting in the right eye, but he's much better. So this lady had a CP angle tumor, a cerebellopontine angle tumor, and she had a combined 6th and 7th nerve palsy. You can see there is a very large ESO deviation and a facial palsy also. So what he did was we underwent and took her for medial rectus recession of the left eye along with a SRT to the lateral rectus and also combined it with the tarsography. So she's better, though the abduction is not 100% there, but it is much better. She's able to read and write well. So in a nutshell, HP in a restrictive and paralytic strabismus could be to attain BSV, to prevent diplopia, or to increase the separation of the images. So the goal is to identify the cause and treat it, weaken the tight muscle, strengthen the weak muscle, or a combination of both so that there is ocular motility improvement, reducing diplopia in primary gaze and enabling binocular single vision. Thank you very much.
Thank you, Dr. Neena. I have a question. You have shown many SRT, right? What is your experience about vertical? Have you encountered any vertical?
Yeah. So, yes, I have encountered a few vertical, but young children did not complain because obviously they will suppress. But the gentleman with the pontine stroke, he had a vertical deviation, but it reduced with time. So he wasn't very symptomatic, but in one patient I had to give a vertical prism.
Okay.
So it can happen.
The SRTs you have shown.
Madam, mic is there, madam?
Yeah, there is a mic. The SRTs you have shown are all just SRT or you augmented?
It depends. In DRS, I do not augment it, but in a 6-nerve palsy, depending on the angles, I augment it. But I don't augment with a scleral bite. I just augment them with the muscles. If you take a scleral bite, the chance of torsional diplopia is much more, as demonstrated by Mehendale et al. But it is your surgeon's, preference.
Okay.
One question, Dr. Neena.
Yes.
In Ella palsy and also in DRS with abduction deficiency, what I prefer is Nishidas than superior rectus transposition to lateral rectus. I find that the lid fissure changes, induced vertical deviation are all much less with the Nishidas than. What is your opinion?
Yeah, one of those surgeries in which I did VRT is a very old surgery, but I've shifted to SRTs, and off late I've started doing more of Nishidas. But I've encountered one problem. With Nishida, I'm getting some worsening of the horizontal deviations. Like I had a patient, this child with MAD, he had a small, he had an exophoria, just 16 prisms. Post-surgery, it increased to 25 prisms of exotropia. So I had to put him on patch. So there could be sometimes asymmetric tightening of the rectus muscle. So it's not a titrable surgery. So I think that's something I need to look at on a long term. But as you said, it is a more less invasive procedure and something that we have to consider and something we can easily do.
Have you experience of titrating? You were mentioning how would you always anchor Nishida in between supratemporal or infratemporal or more towards lateral rectus depending upon the deviation?
Yeah, so the thing is, Nishidas, I find that Nishidas gives you anything less than 25, Nishidas works very well. But anything more than 25, I do need a transposition, a true transposition surgery. So I think adjustable Nishida is also there, but I haven't tried it because most of the kids are small. So I think it's a good option probably to see how the adjustments are there. Your experience in this?
I have tried some, but I couldn't correlate. I will just take it more towards lateral rectus in case of larger angle, but couldn't arrive to a conclusion.
No, I've done Nishita, but I bring it close to the lateral rectus. But the same thing, 25 to just around 25, it's okay. Above that, it doesn't work that much.
Yeah, and more than 35, augmentation is better for a transposition.
There is about 25. We have to correct the medial rectus. No. After medial rectus, you do.
Yeah, along with medial rectus. Yeah, along with medial rectus.
But if it's more, then all these other things start.
Nishidas will only improve abduction. It won't correct the horizontal deviation.
No, along with medial rectus. But when the angle is more than 25, it's not very clear.
And one more word of caution with the transposition is that very long-term results are not there. So there is always a chance for overcorrection. So I am very conservative with my medial rectus recessions unless it is very tight. So I do very small medial rectus because eventually some of them go for overcorrections.
And also for DRS, we have to always look for that anomalous LR activity. If it is significant, we should avoid transposition.
Yeah, if there is a globe retraction, I think SRT is not there. You should definitely try a medial rectus, bimedial recession, more on the normal eye. That will be better.
Thank you.
Yeah, I think now I invite Dr. Fatima again to talk on nystagmus and her approach to nystagmus management and AHP.
Good afternoon again. Thank you. My topic was neuroophthalmic causes, which included paralytic strabismus, gaze palsies, which were very well handled by Dr. Nina. So we will just the spasmus Newton syndrome. So what is that? It is infantile onset, variable conjugacy, and with small frequency, low amplitude oscillations. A triad of abnormal head posture, nystagmus, and head oscillations. It improves disappears by 2 to 8 years. You could see the thrust the child gave. But anyway, we have to image because there could be some underlying neurological disorder also. We may not know which patient will be self-limiting the disorder at 2 to 8 years. So if the MRI is normal, we can reassure the patient. So coming to infantile nystagmus, based on the literature nowadays, according to CMAS classification, everything comes under infantile nystagmus, motor as well as sensory. The predominant cause is albinism. Next comes LCA and non-LCA dystrophies, motor, everything. So the conservative management we want to try for nystagmus, there are medications. The brinzolamide is the one I have tried in many patients, but most of them were not compliant. That is different. But few who were compliant were happy. But most often we would not appreciate decrease in frequency of nystagmus, but child or parent would say there is some improvement. The aim of treatment in nystagmus, we all know, it is to shift the null zone. That is to shift the abnormal head posture to the normal head posture. That's all we can do. We cannot do anything more than that. So, and the second aim is to broaden the null zone so that the visual acuity, expanded nystagmus acuity function will be increased by reducing the signal gain of the ocular motor system. This is done by tenotomy and reattachment procedure. And when we try to address the abnormal head posture, we have to address the null zone. The null zone is nothing but where the nystagmus intensity is less, where the fovea gets more time, that foveation time is maximum. So the most common AHP is phase turn in nystagmus, but single AHP usually involves multiple combination, but though one component usually predominates. So how to assess the null zone? It is more like how to assess the abnormal head posture, the same. So allow the child to be in a comfortable environment and allow the child and observe for the AHP or null zone, whatever, without even patient's consciousness, so that you make the child be involved in some activity and you can find out. Then you can also check with accommodation target, because accommodation target can bring out convergence and dampening of nystagmus. That should be also found out. And binocular visual acuity 9 cases would help you to confirm, to verify whether the AHP what we have located is correct. Because suppose if we take left gaze, null zone is there, the patient's visual acuity would be more in the left gaze. So 9 cases binocular visual acuity would help in that terms. If we like to try prisms to simulate Kestenbaum surgery, we have to provide yoked prism. Yoked prism is like providing for base down, this for chin up, we are giving base up prisms, either 20 prism, for 15 degree it needs 30 prism diopter. So we have to go for frontal prism. That may not be suitable in a nystagmus patient, because again the vision will be degraded. So it is for just measuring and confirming the AHP. But considering that, we need not differ prism assessment, prism trial in all patients, because see this almost near to 90 degrees, some 70-80 degree chin up posture. This child, to our surprise, he responded very well to, because mother was not at all willing for any intervention. So we thought with prism somehow we will reduce a bit, but to our surprise, with just 8 prism, glass prism, he was reading the above 3 lines. So we prescribed him prisms and he was comfortable. So it is always better to have a prism trial also before we go in for surgery. The surgery indication would be to broaden the null zone, to improve the cosmesis by reducing the abnormal head posture, and also to prevent neck problem. Timing of surgery, better to defer until 3 or 4 years, because there could be some change in amplitude, directionality and location of null zone. And more than surgery, surgery is technically not at all different or difficult, because same recess resect procedure. The planning and determining the dosage is difficult part in nystagmus surgeries. Importantly, we have to rule out these culprits, like all the alternating nystagmus, because we operate for right face turn, then post-op visit, if they come with left face turn, it is not at all would be good for both patient and surgeon. So how to rule out these alternating nystagmus? We have to spend time. We have to look for alternation, because it may take 2-3 minutes to periodically change. In case of periodic alternating nystagmus, there is aperiodic, to add to confusion. Asymmetric duration is there. So everything should be taken into account. And multiple visits documentation is also important, so that we can be of sure, okay, this is not alternating, this is stable, then only we have to decide for surgery. Occasionally more than one null position could be there, and that null position can be different for distant and near also. That in a rare occasion, report by Stephen Kraft, where he had noted right face turn for near target and left face turn for distant target. So what he has done in this child is, there was dampening on convergence as well. So he has done bimedial recession, artificial divergence surgery, and partly the face turn was corrected. So what is artificial divergence? It is providing, inducing artificially divergence by providing base out prism in each eye, like 6 to 7 prism diopter, and also by adding minus lens, so that we can induce this much convergence, so that the eye will be in divergence and it still get that convergence effect. Surgery, equivalent surgery is bimedial recession. It is effective in fusing patients. So the recession would be of somewhere 5 to 7 millimeter at least. So otherwise the usual nystagmus surgery is to shift the null zone from the whatever 35 PD to the right. If it is there, we have to shift the eyes 35 PD to the left. So these are all the age-old procedures. Anderson procedure is nothing but recession procedures, recession alone. Kestenbaum is recession and resection. What he recommended is 5 millimeter, resect all the muscles. But then Parks, what he recommends is it would not be suitable. So he came with arbitrary numbers 5, 6, 7, 8, and this 5, 6 is for medial rectus number. And this, if you see, one eye you will be doing 6 and 7, and so 6 plus 7 is 13, and 5 and plus 8 is 13. So 13, 13 equal number in different dosage you will be doing. So this is one Anderson procedure we did for 10-degree face turn. So it was 5 millimeter and 8 millimeter recession. Here this eye undergoes exotropia surgery, LR recession, and this eye undergo MR recession. So reasonably okay, the face turn, and but only for 10 degree it is okay. For more than that, everybody thought the Parks recommendation is not sufficient. So the augmentation come into role, where 20% for 20 degree like that, up 21 to 40 degree to 40% augmentation, and 60% for more than 40 degree augmentation. This is from Burton and Kushner. Thanks Dr. Neena for sharing this. Here she had operated for 30 degree face turn. She had done, gone with right stable, where 30% augmentation of classic Park values. So 6.5, 8, 9 and 10 was done in both eyes, and the face turn was corrected. So usually we prefer to keep two muscles at least untouched, so that in future the nystagmus, that is the problem. Future the patient comes.
Excuse me, Dr. Fatima,
Yeah.
you may have to wind up now. We have one more talk.
Yeah. Just I'll rush through on just 1 minute. Augmented Anderson is to avoid resection. We will augment the Anderson. So just here is a case where we did 12 millimeter LR recession and 9 millimeter MR recession. This is augmentation. Then augmentation of further augmentation is by plication augmentation, published by Dr. Muralidhar, where instead of resection, plication he had recommended, because plication is a reversible procedure. That's what the advantage he claims. And this important point I would tell, if there is coexisting heterotropia, we have to do AHP surgery in the fixing eye and heterotropia surgery in the non-fixing eye. And again, this fusion maldevelopment nystagmus, sometimes what will happen if we correct the strabismus alone, the nystagmus would come down because we are giving binocular vision. So this is a case from Dr. Neena, where here this one alone is addressed and the AHP got corrected. So that is also one way of treating. This chin up and down, everything we know. Either based upon up or down, we have to go for inferior rectus. For chin down, instead of inferior rectus resection, we can go for inferior oblique anterior transposition. Similarly, for head tilt, we have to weaken the intorters or weaken the extorters. Thank you. Thank you for listening.
Refractive errors causing abnormal head posture. Dr. Manisha Mohan. She is consultant at Halia Hospital, Palakkad.
At the outset, I would like to thank Dr. Neena ma'am for having me for this IC. So I think most of the audience will relate with this topic with me, because can refractive errors cause abnormal head posture? So the moment a patient comes to us with a head posture, we tend to directly refer it to a strabismologist. And it's like a jigsaw puzzle to us. We don't even want to look at it anymore. So the purpose of an AHP in ocular-driven cases are many, like what we saw. But in case of refraction, it could be to improve vision, to maintain BSV, to improve visual comfort. Okay, so look at the incidence. So you must be wondering, look at the incidence, just one case and two cases in 116, 188 cases, one case of refractive error. Why are we even discussing this then? So even though it is so less, it is our domain because nobody else is going to correct this refractive error except an ophthalmologist. So coming to refractive errors, it could be because of uncorrected or incorrect refraction or an incorrectly made spectacle lens. That's very, very important to know. So as the visual demand increases, the AHP would increase. So you're asking the patient to read from 660 to 69. So you might see the AHP increasing at the level of 612, 69. So because that is visually driven, patient needs to give more concentration at that levels. That's when you're going to see the AHP. And it is abolished by a simple test, which is a pinhole test. Okay, so here is a child. So look at her. So she was watching TV and taken this the video. So she has a right eye 6.6 and left eye 6.24 and has a cylinder of minus 2.5 sil at 20. It's an oblique astigmatism. So with her glasses, she is completely corrected. So she is trying to fixate in the right eye because that had a better eye. So an oblique astigmatism is one of the most common cause of a refractive error. So they can have a face turn or a head tilt or both. So usually you can see that they can have this face turn and try to make this linopic slit effect by using the lid fissures. So that's why they have a face turn. So hyperopia and AHP. So this is a 5-year-old boy who had a AHP of chin down. So a high symmetric hyperopia can present like this. Note that he did not have any significant strabismus nor a AV pattern. So why do they have so? So he is just using a physiological V pattern. So he did not have any significant strabismus, but when the patient has a hyperopia, they tend to accommodate, and when they accommodate, they converge because of the AC by A. So when that happens, when you're doing it for down gaze and the primary gaze, it will hamper the binocular vision, whereas up gaze, because of the small divergence which is usually present in all of us, the binocular vision will not get hampered. So this is myopia and abnormal head posture. So the forward head posture you see in this lady, so usually this is attributed to the adults, the students who adopt inappropriate postures for a long period of time, using gadgets for a long period of time. So we don't know if it's directly related with the myopic power, but probably it's one of the etiological causes leading on to myopia. So another cause is an anisometropia of high degrees. So when you have a patient with the minus 16 refractive error and a 30 mm of an axial length in one eye, and other eye has around 25 mm of axial length, so there is a phenomenon called heavy eye syndrome. So because of that, there is a superior-temporal dislocation of the lens, and because of that, they tend to have a hypo and a ESO in that eye. So to compensate for that hypo, they tend to tilt to one side. So that is nothing but heavy eye syndrome. So just a note on dislocated lenses. So I'm not sure if you can see the lens here. So this is a case of homocystinuria. And an ectopic lentis. So here there is a loss and tear of zonules, and this makes the lens very dynamic. So when the patient is having a right head tilt, the lens kind of tilts to the right. The patient has a left head tilt, the lens kind of tilts to the left. So these patients are very, very difficult to treat. Trial may be needed, and you'll have to give them glasses, send them home, check for the best vision, check for the AHP. If they're having no difficulties, then they can dispense it. Otherwise, we'll have to sometimes just give an unilateral correction. So I was telling you about incorrect spectacle lenses. So myopia, if they're undercorrected or overcorrected, they don't want the visual axis to coincide with the optical axis. So they tend to have a face turn or this look in the sideways in the spectacles. So cylindrical lenses, like I told, most of the times it's a head tilt. Either they would tilt their glasses or they would tilt their head. The easier would be to tilt their head. And then the hyperopes will look through the periphery of the lens. Now refractive errors with nystagmus and strabismus, many a times you could see these overlapping conditions. So this was the same boy who had a high hypermetropic hyperopia and a nystagmus. So now he is using the right face turn because he has a left null gaze for the nystagmus and then the chin down for the hypermetropia. So at least one of the components will get corrected if you correct them with the spectacles. So any wrong prescription or wrong spectacle lens patients can have in head posture because they cannot tolerate, especially the overcorrections with hyperopes and astigmatism. They tend to look over their spectacles. And some children may feel like tilting or turning the head to one side to avoid confusion. This is very common in anisometropia. They tend to use the better seeing eye for that. And anisoconia also, when you have a difference in the plus powers in one eye, when there is a high plus in one eye and other plus in the other eye, they will have different magnification and isoconia. So that can be altered by giving a different base curve and reducing the lens thickness, using the aspheric lens with more positive power, and the economical alternative would be to use a large uncut lens. So some children tend to look through the better seeing eye, and therefore the AHP occurs. So this could be because the select frame which was too large compared to the IPDs. This is very, very common in pediatric age group, because usually the opticals, some opticals don't have the pediatric frames and they would just dispense them off like that. And lenses, if they were cut too large, and also if the glasses were undercorrected or overcorrected, wrong prescription should be noted and correct the refraction and give them the correct spectacle fit. So here I've got the power right, their axis is right, spectacle fit is right. What am I missing? So look at this boy. So he has a chin up. Now with the glasses he is having a chin up, and without the glasses there is no chin elevation. So, but although you can see him squeezing the eyes in the picture without the glasses for the refractive error. So this was the case of a scratch glass. So the problem might be as simple as that. So it was a scratch glass and he was trying to avoid those scratches, and that's why he had a chin up position. So it's always important to take the glasses, have a look at them if they're fine, and then again give the new glasses if required. So to conclude, I would say that AHP due to refractive errors can be due to many reasons, but it occurs due to improvement in visual acuity and better binocular vision in refractive errors, and it is something that must be noted and taken care before anything else. A simple pinhole test is all that is required to diagnose these, and the best part about it is you did not have any referrals. You can do it it can be done by any ophthalmologist. Thank you.
Thank you, Manisha, for that very lucid presentation. And AHPs due to refractive errors is not uncommon. That's the first thing we must rule out. I have a question to Sheben. And how do you differentiate between a true ptosis and a pseudotosis? A quick point before we shut the IC.
You should cover the eye and make the eye straight. Then you evaluate for the toes. That is the only way, and not related to this, but enophthalmos and other causes are there for the pseudotosis that also should be evaluated.
Thank you very much. If you have any queries, you can catch them out, us outside and ask. I would like to give a memento to Dr. Fatima in support of her time and sharing her expertise with us.